We are live.
Good evening, everyone. Welcome to iFocus Online, lecture number 547 of Optics and Refraction, module number 22. Today, we have Mr. Digambar Singh to speak on the topic Spectacles, Magnification, BVD, Aphakia, Effect on Accommodation and Convergence. The moderator for today's class is Dr. Vaibhav Nagpal sir. He has done his MBBS from Seth GS Medical College in Chem Hospital, Mumbai, and MS Ophthalmology from Maulana Azad Medical College. He's done his fellowship in cornea from LVPI. Currently, is the faculty at Shantilal Sangvi Eye Institute, Mumbai. He is a cornea and anterior segment surgeon. He has received Best Free Paper Award at Winter DOS in 2019. Sir has numerous publications in national and international journals and has participated in multiple national and international conferences. We welcome you, sir. The chairperson for today's class is Professor Monica Chaudhary ma'am. Ma'am is the director of the Monica Chaudhary Vision and Eye Care Clinic in Gurgaon. She's also the founder of Learn Beyond Vision, which is an online teaching platform. Ma'am has over 40 years of experience and has expertise in contact lenses and specialty lenses, myopia control and orthokeratology, low vision rehabilitation, and pediatric eye exams and amblyopia treatment. Ma'am has received multiple awards and honors. To name a few, these are Shri Award from the Delhi Citizen Forum, Australian Leadership Award, and Global Best Contact Lens Education Award in 2015. She has multiple publications, out of which few of the books she has authored is the Contact Lens Primer, Low Vision, Refraction, and Lens Prescription. We welcome you, ma'am. The speaker for today's class is Mr. Digambar Singh Bisht. He has done his bachelor's degree in optometry and ophthalmic techniques from Eye Care Eye Institute, Noida. His post graduation is in hospital management from Bellinker Institute in Pune. He has over 12 years of clinical experience in optometry and refractive surgery support. He's also the regional head optometrist at Center for Sight Group of Eye Hospitals. He has expertise in LASIK, Smile, Silk, and cataract platforms. He's also certified system operator of Visumax, Vizex S4, Catalyst, Silk, and Elita. He has actively participated in many clinical research, which includes Johnson & Johnson, Cheetah Refractive Program, and Zeiss Lisa IOL study. He has received first runner-up Optometrist of the Year award in 2017 as well. We welcome you, Digambarji. Over to you.
Thank you so much. Let me. Good evening, everyone. Respected Chairperson, Ma'am, Dr. Monica, Ma'am, and Moderator, Dr. Vaibhav, Sir. Namaste, all. I just want to share my slide shares. Is it visible? Am I audible?
Yes, sir, you are.
Yeah. My slides are visible?
Yes, these are visible.
So today I will be focusing and discussing the optical and clinical aspects of spectacles, mainly the magnification, vertex distance, and how they impact accommodation and convergence. So here is the overview. We will include the spectacle magnification, back vertex distance, aphakia and spectacle correction, effects on magnification, effects on convergence, and then finally the clinical consideration. So we will go step by step. So why this topic matters? Every spectacle lens changes images. Vertex distance affect the lens power, basically the effective power. Aphakia make these effect stronger. Knowing these help us to deliver better vision and comfort to the patient. So here is the spectacle magnification, which is defined as the ratio of retinal image size with spectacle to without lens, basically the unaided image. So the unit of magnification is represented by the x. For example, 4x means 4 times magnification. It means how much bigger or smaller an image looks through the glasses. It depends upon the lens power, thickness, curvature, and the position, basically the back vertex distance. So the plus power, it means the bigger image, minus lenses basically means smaller image, which means magnification. So what are the factors that can affect magnification? Basically the lens power, more plus, more magnification, vertex distance, lens, if the lens is farther, then there will be more magnification. Thickness, if the central thickness increases, there will be more magnification, but with the refractive index, if it increases, the magnification decreases. All right, here in the picture, you can see here with 1.5 index of spectacle lens, you can see that average thickness is 9.4 millimeters. But with the 1.7 index, you can see the reduction of the central thickness. So hence the magnification will also reduce. So the formula for spectacle magnification is, you can see in this equation here, the spectacle magnification, where the V is the vertex distance, which should be in meters. F is the front surface power. As we know that a spectacle lens will have front surface power and back surface power. So basically, generally the lenses are in the meniscus form. So suppose, for example, I can tell you, if you want to generate a +2 diopter lens, so you may have front surface with +6 and the back surface with +4. So finally, you will get the +2 diopter, right? The T is the central thickness, which should be always in the meters to calculate the spectacle magnification, and N is the refractive index. For example, if you can see here, I have converted the vertex distance, which should be in millimeters usually, because it will be 12.5 millimeters. So I have converted it into the meters. Then suppose the power is 10 diopter and the central thickness is 0.0071 meters and the refractive index is 1.71. So hence you can see here with the formula, the spectacle magnification will be 1.19x, means at least 1 times magnified image you can receive with the spectacle lens, with the 10 diopter spectacle lens. So magnification can be also expressed as the ratio of image height to the object height. So generally we can consider it like that, but it cannot be measured in that way. In eye, we cannot measure it, but yes, we can expect the spectacle magnification with this particular equation, right? Means higher the spectacle power, higher the spectacle magnification. So now, followed by the same thing, the back vertex distance, as I already told you, magnification will be affected by the back vertex distance also. So what is back vertex distance? It is the distance from back surface of the spectacle lens to the corneal plane. So in plus power, it means if the lens will go farther, the effective power of the spectacle lens uh, will increase, right? So important for the high power lenses, because with the high power, this equation will work very faster. Means there, if there is a smaller change, there will be a big difference with the spectacle power also. Small change in BVD, significant change in effective power. This will be applicable especially in case of high power lenses. You can see, means you can see the change. You can even see the change if you do the simple lensometry with these high powered plus lenses or high powered minus lenses. If there is a small 1 to 2 millimeter uh, slant, then there will be a significant change in the spectacle power also. For example, plus 10 diopter lens moved 5 millimeter closer, power will be reduced by at least zero 0.5 diopter. So vice versa, if you will go farther, then the power will increase. All right. So it is very important in such cases. You need to measure the front the back vertex distance. So it is very easy to measure with a simple transparent scale, you can measure it, right? And these days there are many tools incorporated with AI tools, so they can give you the figures, right? Back vertex distance, pentoscopic tilt, etc., etc. So clinical relevance of the back vertex distance essential when converting refraction from trial lens to the spectacle power, because these days there are trendy frames, and according to the frames, the back vertex distance of that frame will also change. So we need to measure so that in the laboratory they can compensate it accordingly, right? So here you can see in this picture, it is very simply measured by a transparent scale also. All right. Sometimes patient may have a tendency to wear glasses at very far from the from usual distance, and it is mandatory to record BVD in high myopia and high hypermetropia, which is already given in the calculator. Suppose if you are calculating any phakic IOLs, in that case, you may need backwards distance, and you can see the significant change in the phakic IOL power if you change the BVD. So incorrect BVD, there will be definitely a blurred vision, and maybe if patient is able to compensate, patient is able to cooperate with the bad BVD, in that case, they may develop asthenopia symptoms. So here you can see in the ray diagram, hyperopic significance of the vertex distance, and in myopia also you can see this significant change and significant ray diagram change. Here you can see if you can see the incoming rays from the plus lens is still converging. So definitely it will also affect the convergence. And you can see in myopia, the incoming rays from the minus lens is diverging. Definitely, it will also affect the convergence and accommodation. So that we will discuss in the later slides. But you can see, as we define metropia with the contact lenses, there will be least change in the ray diagram, means it is a normal ray diagram. You can see here in the lower slide, in this picture with myopia and hypermetropia. So now I'm going to discuss aphakia. The optical correction options are spectacle, contact lenses, and intraocular lenses, right? So aphakic spectacle characteristics are high plus lenses, that will be plus 10 to plus 12, sometimes more than that. And the magnification, as we have seen in this spectacle magnification equation, you can see the magnification may increase by 25 to 30%. Theoretically, it has written like that. With the plus 10 in aphakic conditions, you may get at least 30 to 40% of magnification, and reduced field of view because of the reduced diameter, right? So because of the image jump, the borders of uh, blurred and clear vision zone, there will be a ring scotoma that will form. So it will be just like a jack in a box effect, and a image jump at a segment line in bifocals, specifically because patient is aphakic and there is no accommodation, then definitely they may need bifocals. So in that case, there will be a sudden jump. Here you can see in this picture the spectacle versus contact lenses, how the vertex distance, how the thickness of the contact lens is affecting the overall image size. So there is a comparison, spectacle versus contact lenses versus IOL in aphakia. So the parameter are, if the magnification you will receive by spectacle lens will be 30%, then in contact lenses it will be significantly reduced by 20% at least, and in IOL it will be negligible. If you consider the binocular vision with the spectacle lens, definitely aphakia is very rare binocularly, but it definitely it is possible sometimes. Suppose there is a case of trauma or any surgical surprise or any post-surgical consequences are there, then in that case, it will be very difficult to manage with the spectacles. If suppose one eye is plus 10 and other eye is plano, in that case, there will be an iconia, then that's why there will be no or nil binocular vision. With the contact lenses, it will be better because the magnification has significantly reduced, and there is one more uh, physics is there, that will be the prismatic effect, well, that we will discuss in the later slide. And with the IOL, it will be normal. Normal means normally as we expect with a normal eye, means a eye with isometropia. Field of view, it will be reduced with the spectacle lens, as I discussed, and with contact lenses it will be wider and wider with the IOL also. All right. And in otherwise, it cosmesis wise, if you can see, it will be very poor with the spectacles. Contact lenses, with the contact lenses it will be good, but still you will be able to see the margin of the plus correction over the cornea, so you can see the optical zone if you see with the torch. And it will be excellent because it will be hidden by uh, it will be hidden by the iris diaphragm, right? So what are the effect on the accommodation? In aphakia, definitely there will be nil accommodation, hence there will be no effect on accommodation. With the spectacle correction, definitely the image formed farther, it will minimize the accommodation demand. In myopic correction, it will reduce the accommodation requirement. And in hyperopic correction, it will increase the accommodation effort. How? That I will show you in a Dre diagram. So effect on convergence, definitely the convergence and accommodation both are correlated and both are equally, you can see if you converge at nears, definitely there is a ratio that is 3 to 5 prism diopter of convergence will induce, will you will need at least one diopter of accommodation, right? So in plus lenses in hyperopes, you can see eyes converge more due to the base out effect. As you can see in this diagram, it has been shown. Base out effect means if you converge, so you are not seeing through the center of the lenses, you are seeing through the nasal ends of the lenses, nasal ends of the spectacle lenses. So base out prism at near, more accommodation demand will be there, and there will be a ESO kind of shift, and it will be less with the CLs, because with with contact lenses, whenever you move your eye, whenever you converge, your contact lens will also go together, and definitely there will be no prismatic effect. And in minus, you can see here in this picture again, there is a base in effect. So in base in effect, there will be less accommodation demand. So you will expect a false working distance for near work. Specifically, suppose if there is a 33 centimeter, uh, you keep a near object at 33 centimeter, so you will receive it at 40 centimeter or so. So here, that's how it is happening because of the prismatic effect. So prismatic effect significantly, it is very significant for near tasks. Means whenever we are prescribing such kind of power difference, either it is hyperopic or myopic patient, we always have to check the near vision at least, and then we have to sometimes uh, tell them about the adaptation and the situation, means magnification situation and minification situation. Along with that, we have to share the point that whatever you will see with the plus lens, you may see it at very near, and with minus lenses you may be able to see it slightly far, means there will be slightly false projection. So how it is, why this is happening? This is happening due to the prismatic effect. here is a simple rule, that is the Prentice rule, which is P is equal to C into F, where P is prisms, and C is the decentration, and F is the lens power in diopters. So decentration will be calculated in centimeters, means first we have to convert the decentration in centimeters. It is very, very important in high corrections, high refractive errors, and bifocals. For example, if the P is the prism, and C is suppose 0.5 centimeters, means if it is 5 millimeters, it can be induced, because it dependent upon how good they are fitting it. If it is geometrically centered, then there will be no errors. But if it is falsely fitted according to the frame size, then you may induce at least 0.5 to 1 centimeter of distillation binocularly, right? If the lens power is 10 diopter, then this calculation you can see, and you can understand how it can affect the overall situation or on convergence and accommodation. So then the P is 5 PD, means with 0.5 centimeters of decentration, you can receive 5 PD of prismatic diopter of prismatic effect. So a prism with a power of 1 prism diopter will deflect a beam of light 1 centimeter at a distance of 1 meter, right? So suppose the patient's decentration with the spectacles is horizontally displaced. In that case, patient can compensate it with the time. But suppose if it is vertically displaced, then it will be very, very difficult to manage, because vertical tolerance, as we know that it is very least tolerable beyond even with 3 prism diopter of displacement is there, then it will not be tolerated by the patient. So here you can see, suppose if there is a minus lens, so if it is geometrically centered, and if it is well fitted with optical centers, so there will be patient will be very much comfortable. There will be no prismatic effect. And if you see in the C image, in the C, you can see the base in prism because of the decentration, poorly fitted lenses, you can see. And similarly in D, you can see the base out prism effect. And this in E, you can see base of prism. In the right eye, you can see here. Apex is means if you can consider this minus lens as apex to apex, then in that case, you can see how much decentration you can receive and how much prismatic effect patient can experience. And vice versa, in F, you can see the base down effect. So clinical management tips, we are suggesting measure and record BVD in high power lens at least. It is a best practice that if you are refracting a patient, check the BVD with a simple scale. Then always, whenever you are suggest in optical means, this is my suggestion to the optical people, to optical staff, they have to see what is the actual BVD with the frame. Then they can compensate it, means they have to share this figure to the lab, and they will compensate it, means they will change the effective power accordingly. Prefer aspheric lenses to minimize distortion, definitely. Why? How? Means, see, in periphery, the lens will get flatter in high minus, and similarly with the high plus lenses. So it will minimize the distortion, because how it is happening. This is because of the Prentice rule. In aphakia, encourage contact lens or IOL correction rather than prescribing them glasses, rather than prescribing them compromised balanced glasses. educate patient about image size difference and adaptation period, because as we have seen in how uh, how that accommodation and convergence is getting affected with high powered lenses. So we have to tell them that there will be a false projection with the spectacle lenses. So here is a scope for contact lens. You can ask your patient to go for go for the contact lenses. So here is the summary. The magnification depends on the lens design, power, and BVD. BVD affects effective power and visual comfort. Aphakic spectacle cause high magnification and distortion. Accommodation and convergence are altered by high power lenses. So here we have shared these information through the references. Thank you so much. Thank you so much for inviting me here in iFocus. And I'm here to listen from you that if is there any question or any discussion we want to share.
Yeah, great presentation, Mr. Digambar Singh. Very detailed and a lot of points you have touched. So I would just like to start with some addition to your thought process about back vertex distance. So, and I would like our listeners to benefit. What is the role of back vertex distance when you are converting the power from spectacle to contact lenses? If you can shed some light on that topic, that is, I think, very important.
So yeah, so there are charts given online, and we can share with you. Right now, I do not have that particular chart, but it is very easy to convert, and it is more effective after 4 diopters, and it will be very significant after 10 diopters.
Yeah.
So whenever you are converting, there is a very simple equation with minus. With minus, if you are going for the contact lenses, the power will reduce after 4. With plus, the power will increase after 4. So this is a very simple logic we have to understand, and we always have to cross check so that there will be least error.
Yeah. So my point was only to reiterate the point about this topic, that when we are understanding about back vertex distance, just the small things which we learn, that when you keep your hyperopic glasses away, they become stronger, and when you keep them nearer to the eye, they become weaker. So it is basically the image which is going from nearer from the focal plane to far away. That is how things change. That is one point I would like to stress upon. Any inputs, Dr. Professor Monica, about this topic?
Yeah. So very nice. Thank you, Digambar, for it. A big difference when it is above 4 diopters in contact lenses. There are formulas for it, and then there are tables where we directly match into it. Rightly said, minus reduces, plus increases when we shift from spectacle to contact lenses. The second thing is, now let's say the patient has a prescription of minus 13. Very common nowadays to see high powers. And the patient is wearing the spectacle at a particular vertex distance, which is something like minus 12. When you put in a trial frame, our regular trial frames do not measure the side temple vertex distance. If you have a good branded trial frame, you would see that the vertex distance is actually 12, 13, 14. So the practical implications come. We've done the trial frame, and we might get a power as minus 13 or 14. The glasses are made and come back, but the patient starts wearing it at a different vertex distance.
Sure.
Right? The whole story will change. The 14, if it is closer, will behave as 14.5. And that minus 14, if it is a little away, behaves as 13. So the idea should be using Haber clips, and in high minus, you remain with the same vertex distance. And many times we would do the refraction add on over the spectacle plane. Very important, we mention in the patient's prescription to maintain the same vertex distance as the old prescription. So patients come back with high powers, returning with the complaint, I can't see as well. The trial frame vision was good, but this is not good. So small changes in vertex distance make a big difference in the quantity of vision and the patient's comfort also. Interestingly, you would find some myopes getting into a trend of wearing the glasses a little away from the eyes, more at the tip of the nose. A very simple example of this gives you an idea that this patient is probably overcorrected myope and hence tends to bring the glass forward so that the effective power becomes less. The second thing is plus power patients, similarly, if they're trying to go away from the eye, that means they are taking more plus. We need to just increase it. Or if a myope holds a glass and tries to read the chart, taking it a little closer to the eye, making it sharper, clearly tells you you need to work on the powers based on vertex distance and not in the trial frame. Second point, I would say that yes, conversion from contact lens to spectacle to contact lenses, the accommodation convergence system that totally rephrases. In ESO deviations, contact lenses, especially the accommodative ones, it is like a boon. It controls or it relaxes the accommodation so much that contact lenses will show better control in accommodative convergence squints. So these are few practical applications. And when we talk about myopes and hypermetropes, a myope, if you will shift to a contact lens, will get into early presbyopia.
Yes.
It's a big risk shifting a 39-year-old myope into a contact lens because the accommodation demand reduces and they may get into a presbyopic thing. So I think few points. Of course, the first point was aphakia and in the others may matter. Unilateral aphakias, no way spectacles. We need contact lenses or secondary implants. There is no solution other than this. We've never succeeded in binocular vision with them, but contact lenses immediately solve the problem. And if possible, once the contact lens is stable and finalized, we've even had patients referred for secondary IOLs. The power calculations become easy and the assessments are easier because time and on we find squints with the aphakic patients because they are long-standing and not corrected. So give a contact lens, manage the squint, and then ultimately a surgery is the best option. So the whole story goes back to the fact that contact lenses, yes, behave better. The vertex distance is a big, big miss in dispensing. The sales counter people do not have that science to understand, but the optometrist or the eye care practitioner who has prescribed anything above 4 diopters, make sure your vertex distance is mentioned and specified to the patient that when they change the frame, let the frame be at the similar position where they are habitually used to.
Great points, Professor Monica. So, would just like to add about your point when we shift myopes to CLs. So, the same thing goes when these patients with very high myopia either shift to CL or we give they underwent LASIK or ICL because as Mr. Digambar showed that slide that when myopes are using glasses, there is a basin effect and they don't need to accommodate a lot, though they don't need to converge a lot. And when we shift them to CLs or to ICL or LASIK, so they need a lot of accommodative effort now. They have to use their accommodation more. So would just like to tell the audience that you have to counsel your myopes when you are shifting them to CL or planning ICL or LASIK, that they will need more accommodation than previously and they should be prepared for that. Would just like to also have your opinion about managing anisokenia in aphakia. So just because a lot of people don't understand what anisokenia is. So Mr. Digambar told that when you give plus 10 lenses, there is a magnification factor of about 19 to 30. So the image
30%.
size 30%. So the image size is actually 30% larger. And physiologically, a brain can fuse an image which is about 10% different. So with CL, the brain can fuse it, but with spherical glasses, they may not be able to fuse it, and that will create problems for the patient in binocularity, and they may not be very happy about that. That is one more thing just wanted to add.
So anisoconia now depends on also, it's said anisometropia when we are more than one diopter. There have been patients who have been about three diopters of anisometropia and have shown fusion. Now the differences are, practical things are, axial anisometropia, or is it the index? What type of it? Now all axial or refractive. When it is axial anisometropia, the fusion does happen. So if it's axial anisometropia, -1, -10, the image sizes are same if the eyeball size is the differential or has been the cause of it. So the patient with even this, like we've had a child who's -10, other one in one eye and in another eye. And after doing keratometry and axial length, it totally interprets that 10 diopter is because of the axial length increase. Fusion will, because -10 magnification will match the -1. So important point in assumptions. Now, aphakia is a different story. Aphakia is totally because we're at the nodal point plane and other things. But if you just have anisometropia, and you've seen cases in clinic, there are times when we just don't understand. There are 4 diopters of difference and they're fusing. If we do binocular assessments, different grades, maybe the stereopsis would not be the best, but there is SMPs and fusion. So is it axial? And in all probabilities, axial anisometropia in terms of anisoconia fuses. Cosmetic issues may come up.
Yeah, very, very great point. So that is always a clinical discussion in the OPD when a patient comes to you with -2 and -8 in the other eye, and you think that if you prescribe -2 in one and -8, he will have diplopia. But you are surprised that the patient doesn't have diplopia because it is axial ametropia and it doesn't cause. So mainly refractive and ametropia and isometropia will maybe causing the change in the image size, but not the axial ametropia. Very good point, Professor Mankar.
Yeah. So all these behaviors, of course, binocular function tests have to be done. I would say these basic tests of this are important. So the judgment of shifting to contact lenses is totally. So as I said, this -1, -10 is a 1-year-old child. Where is the contact lens going? However, contact lens is giving you a wider field of vision, the optics, cosmetics, there are advantages. But just jumping on to the fact of anisoconia, and this is the theoretical difference of percentages, it's not that way. What is the image size at the retina level will depend upon the eyeball size.
Understood. A very good point.
Even anterior dislocation of the lens, posterior dislocation of the lens, even that varies the image sizes. So
yeah, one more point about these days, a lot of young chaps come with cat eye glasses. Like they will have big glasses and they will give a very typical history that recently we bought these new glasses and we have started headaches. So Mr. Digambar Singh's highlighted about the fact of decentration. So in general, they would be seeing from the upper only the tip of the lens and their center would be here. So some stress on that point would be great in this lecture.
yes, so unfortunately, our optical segment in the country is not regulated, and hence the guidelines are not so thorough in many of the showrooms. The opticians usually assume that the single vision glasses do not need centering, which is wrong. And if we talk about progressive, they've learned the fact of monocular PD and they try to do the best into it. But single vision glasses, whenever we cross 4 diopters and the prism difference is much. So let's say it's a 10 diopter spectacle lens. If the decentration is going by 1 millimeter, we are creating a 10 prism.
Yeah.
So that kind of effects are happening, and the centering frames, the fitting, everything is so important. Where does the patient look? So frame selection makes the whole science there if they're going to go. It can be that, yes, if the frame is not, I mean, people pick up the choice of their frames, and you're right to say they're looking, peeping through the upper zone only. It's fine. Centering can be done at that point. Proper PDs can be done. The blank size has to be very big. Now, those big frames, what you said, usually have 65 or 70 size blank, which will not fit in that two big frames. So they mark the center is never going to be accurate. Either we get customized. So big frames need much customized blanks, which is not happening always. And one prism, as vertical prism, Digambar said, is the most difficult to handle and for the brain to even fuse. So centering makes a big difference in comfort. It's all the science of the prism induced with that glass. Patient looking through the wrong visual axis, inducing a prism. Above 4 diopters, totally no. The tolerances go very bad in that case. Even 2 prism diopters are very difficult to tolerate if it is a vertical difference between the two.
Yeah. A small topic about Jack in the Box phenomena we were talking, and it becomes very difficult for the postgraduates to understand what does Jack in the Box mean and what is the importance of spherical aberration in high-powered glasses. If some discussion can happen on this point, would be great.
I know Jack in the Box is more like a kind of diagrammatic explanation, but I'll try to explain.
Should I share? I have something available.
Yeah.
I just
So
share that. So I was just going through before coming.
Now, very right. This diagram, if you see, now it's trying, the top picture is trying to show that the patient is looking at an object which is oblique, right? Now, there is a prismatic effect in this. As I said, 10 diopters even can go to 10 prisms. Now, because of that prismatic effect, the object seems to be at a different position. And when the patient looks at that position, suddenly it goes off. It will go off his view because of that prismatic effect. So Jack in the Box, he suddenly sees the field of vision in an aphakic is about 50 to 60 degrees. So when he is looking something beyond that, he sees the object and suddenly he sees the object goes off because the object has shifted to a much different position.
So basically, the object appears in the temporal field of the patient,
and
but we discussed
out
about the ring scotoma, because as we go from center to the periphery, the power of the glass increases. That means the prismatic effect increases. So the rays which are actually in the periphery, they focus much before the point, and we actually miss. So there is a ring scotoma where we are actually not seeing a part of the field of view.
So total 360 degrees, I would say about 55 degrees in an aphakic glass or a plus power, the image will jump out of the spectacle or the view field of vision. So Jack in the Box suddenly says the object has jumped out and he would have the object coming in. So that is how Jack in the Box phenomena is described. So lenticular spectacle lenses to certain extent have solved. Second practical tip to give to this patient is that if they have to look to the side, they have to move their head or the nose to point at it. So wherever, if they have to look temporally, it's not the eye which should move. It should be the nose pointing there or the head pointing towards that. That will avoid the Jack in the Box phenomena. Lenticular lenses also have only a small optic zone, which makes the patient actually turn the head and look into.
Correct. So this is a very important clinical point that we instruct the patient, because reflexly they will move their eye, but they actually have to move their head, and this is where training of the patients with these spectacles comes in very handy. Also about the point of the objects appear much nearer in these glasses. Actually, this also is the same point because of that, and maybe something upon that would be great.
So the object, again, it's the principle of magnification. plus lenses causing magnification, and hence the objects look closer, and the depth perception goes off. In minus, it is minification in a way. Very clear. Sometimes we come across our patients when we shift them to contact lenses, they suddenly would say that I looked into my mirror and I found myself being much bigger in size and wider. It is actually the true size.
Yeah.
They think everything is looking bigger to me. It is actually the true size, but because of the myopic glasses, minification was happening, and hence they were seeing things which were
Very small.
smaller, relatively smaller, or virtually smaller than what the realities are. So, big science in optical dispensing, I would say.
Yeah.
And a good refraction totally fails if the dispensing is not done properly. The right judgment of glasses, frame selection, the prism is totally a untapped area, but makes big differences if you have even exo deviations, 4 years, ESOs. I work a lot on prisms, and I find amazing differences with just prescribing 2 prisms, even in many patients with comforts that come in.
Great points, Professor Monica. We had a great discussion, I think, and it was a great session by Mr. Digambar, and some clinical inputs were great. Thank you. Thank you so much.
Thank you so much.
Thank you, Monica.
Thank you. We have a question actually, if just Digambarji can answer. There's one question which is how magnification induced by a spectacle is different from that induced by a magnifier, which is used for the low vision aids.
So basically, there is a concept which is known as angular magnification. Means we need to understand the type of magnification that is induced by the spectacle and the magnifier. So spectacle magnifier means with the spectacle you will see the image change at the point of fovea. Basically, there is a retinal image change. So that you are receiving with the spectacles. But with the magnifiers, you are actually receiving that magnification at the level of the tool. So closer you will go towards the device, you will get a better field of view and better magnification. But with the spectacle, what will happen if you will go closer with the spectacle lens, the magnification reduces, right? So there is a difference between a concept which is known as angular magnification, that is happening due to the handheld magnification or any kind of stand magnification, and spectacle magnification have a different concept because it is happening at the level of fovea.
Okay. And another question on our online platform is something related to the contact lens. Why is the field of vision more with the contact lenses than the IOL in cases of aphakics?
See, aphakia is not normal, or it is not, it is generally not congenital, right? So aphakia means something had happened in the past, means maybe there was a history of trauma, maybe during the surgery or after the surgery any consequences happened. So that may affect the overall system of the eye, means the iris diameter and basically the sulcus, the position of the sulcus. So as we know that IOL have a limitation, means it is not a limitation. IOL has a limited optic size, that is 6 millimeter. So sometimes if the patient is aphakic plus the patient pupil is not normal, means it is somewhat dilated because of any history of trauma, in that case there is a good option that you can prescribe them contact lenses, because in contact lenses you can do the alteration, you can change the optic size, and it is reversible also, means reversible in terms of, means you can reproduce it. But suppose IOL is placed In that case, you cannot keep on altering the situation. You cannot keep on changing the IOL. So sometimes it will be wider, but with IOL it will be normal. But in such cases it will be wider. So I have kept both the things together. One is wider, one is normal. Normal means generally what we expect with the emmetropic patient. And in contact lenses, suppose the normal soft contact lenses is not helping. In such cases, we can even provide scleral contact lenses so that we can maintain the optic size. We can increase the optic size, and hence we can increase. Suppose this patient is fixing the fixation at one point, so because of the larger optic size, patient may get good field of vision. And in suppose a patient who have a situation like that, pupil is not normal, means if it is a fixed pupil or somewhat dilated type pupil, in that case, due to the margin of the optic, so sometimes patient may get two focal points, and due to that patient may get diffraction. So sometimes patient may get glare also. So in such cases also, you can provide contact lenses, or over the contact lenses you can prescribe spectacle lenses or tinted spectacle lenses to avoid such situations.
I think the question actually was because of the depth of focus. Field of vision is wider in contact lens or this. I don't see a science in it, or I would rather say the whole. It can be IOL also having better field of vision than the contact lens. It all depends upon the pupil size. If the pupil size is very small, then the depth of focus is much more. It can happen with the contact lens, the IOL also, and rest the Digambar.
Yes, ma'am. Because aphakia is not normal, so you may get add-on situations, means the other elements also may affect it with aphakia. Sometimes cornea have sutures because of the trauma. You may get altered refraction with deformed cornea. So sometimes placing a IOL is not a good option. In such case, I have just recently done a patient. I have fitted a scleral contact lenses, and patient got very good vision because of the corneal irregularity. So refraction with the spectacle lens, the patient's vision was only 6/24, but with contact lens, patient vision was very good. It was 6/6, and he was happy. So his surgery was postponed for a time. Now we can see such kind of situation also, and with field of view, definitely it is comparable. I mean, with IOL and with contact lenses, both are comparable.
Okay, sir. We don't have many more questions. I think if ma'am and sir allow, we can call it a day.
Yeah, definitely. We had a great discussion. Thanks to Professor Monica, Mr. Digambar. And yeah, any inputs, Professor Monica?
No, thank you so much. I think very relevant topics covered today. And thank you, Dr. Weber, for bringing in those points and moderating that.
Thank you, everybody. So then, good night. See you in the
Good
next
night.
one.
Thank you,
Right, ma'am.
Digambar.
Thank
For the
Thank you
class.
for your
I just
attention.
have,
I'm very happy to.
yeah, thank you. Thank you.